What do you see as more important in the biology of oligometastatic disease and likely long-term outcome? The de novo biology of oligometastatic disease, meaning at the diagnosis point, or a great induced oligometastatic disease state after a robust response to systemic therapy in a patient who didn't start with just a few metastatic sites? I think there was one other person who had an interest in that question. I think it's an outstanding question. I think personally, without enough biologic insight, I would say that I would personally rather have a patient of mine have oligometastatic disease from diagnosis and who sustained that oligometastatic disease state through the course of several months of time before we would consider local consolidation. The reason for that is that I almost look at our small cell experiences. Small cell lung cancer is certainly a different cancer, but those patients often respond very rapidly to chemotherapy and radiation therapy. And I think the same reasons biologically that they respond rapidly to chemoradiation are the same reasons they recur. And so they have a different kind of biology. And so I would want to see someone demonstrate stable oligometastatic disease over the course of months, if not longer. And I would have probably a stronger hope that using local therapy in those patients where they haven't figured, their disease hasn't figured out how to met out to more sites is probably a better chance at a better at a better outcome. Julia, did you want to say anything about that, or did you?
Yeah, I agree. I think I find it, again, I think we need more data. In my own practice, I'm much more comfortable thinking about aggressive consolidation therapy for someone who truly appears to have very limited initial upfront disease. And then I hope that there is that chance. Maybe we're lucky and those are the only sites of disease and we can go after them aggressively. And I'll discuss that with my patients. For those who've had more extensive disease but have a good response to treatment, like a response to targeted therapy, I'm less likely to do consolidation treatment right now because I don't know which lesions are going to be the ones that are the problem lesion in the future where I'm going to want to treat it. So I'm less aggressive in that setting and will usually focus on continuing the systemic therapy. But I agree, it's an evolving area, and I don't think we know for sure which is the best option right now.
And I think, that's why I think a lot of people will wait for oligoprogressive states, that if there's oligoprogressive disease, that they must have been on systemic therapy for quite a bit of time, and they only still have a few limited sites that are evolving, and maybe the local therapy will help with those with those evolving sites and allow the patients to stay on the same systemic therapy that's working in 90% of sites or something.